He has developed his name. This is a very good people spender we are using, very cheap in comparison to imported people spenders.
Okay. So how many of you have already heard this presentation? If none of you have, then it's worth it. Otherwise, it's revision for you and revision for the nth time for me. So let's go through this because nothing much has changed in the last year or so. So let me begin with a scenario. So small pupil IFIS and pupil expansion devices. Small things which we can take note of as we go. Let's look at this particular case, and this is what we would call an averagely dilated pupil, and which probably is not a very big concern for seasoned phaco surgeons. Not many of you would choose to probably use any pupil expanders or iris hooks in this. Now, when I was just doing that viscoelastic injection, I noticed a bit of iris prolapse, and so I chose to use a pupil expander. And well, we did have a nice expanded pupil, but let's see what happened somewhere down the line. Well, I have a iris prolapsing through the side port, and that's making life difficult despite the pupil expander. And somewhere down the here, we have already got iris prolapsing through the main incision. So what I'm trying to drive at is IFIS is a very different animal, and pupil expanders or iris hooks really don't do much about to prevent the iris prolapse. What they do is give you a constant pupil size so that you can work safely and have constant visibility. IFIS is very common in India, and that has been proven in this paper. The incidence is in fact much higher than the Western world, and hypertension is an important risk factor along with other things. So this is a chart which tells us that no amount of history taking is going to be foolproof, and every alternate patient is a potential IFIS candidate. We've all often talked about what is a safe pre-op pupil size. Well, this is a paper published in 2011, and which says that 7 millimeter or smaller pupil, the risk of IFIS exists irrespective of alpha blockers. So, like I said, iris hooks and pupil expander do not eliminate the risk of iris prolapse, but they do provide a dilated pupil providing visibility and safety, and that's where is their role. So we need to understand that there are basically two types of small pupils. There are the rigid, non-elastic small pupils and the elastic IFIS pupil. The two need to be dealt very differently. They are two different ball games. So let's look at IFIS. Now this is a what we got grade 1 IFIS, where there's just a little bit of undulation of that iris over there, and this is really not a problem. But this is a full-blown iris where you have IFIS, where you have the pupil coming down on you. Nothing wrong with the flow rate, but the pupil just chooses to come down. And it's elastic pupil, you can again inflate the anterior chamber, and it will. These are very old videos, so you'll have to bear with me for the quality. And in fact, this was much before IFIS was probably recognized. And then we have a situation where I've used iris hooks, and even before I completed my Capsulorhexis, there was so much of iris prolapse, and I reposited time and again that I had a frayed iris by the time I got my phaco probe in. So that's the entire spectrum of IFIS. IFIS is very unpredictable, and we need to brace ourselves and be prepared for any situation. So, and more importantly, tamsulicin or other factors which cause IFIS, and tamsulicin particularly, even if you stop tamsulicin, it really makes no difference. The features of the iris remain the same, and it could be 3 to 7 days of starting tamsulicin, or even after stopping tamsulicin, you would have the effect. So these are all the complications that you can have, and you could all prevent a lot of this by using iris hooks or pupil expansion devices. So the bottom line is that pupil stretching is not effective in IFIS. You must remember that. You'll stretch and it'll come back again. So you need a device in place to hold it so that that pupil does not come down smaller than what you want to work. There are the various devices, the iris hooks, the Mulligan ring, and the BHEX pupil expander. This is a brief overview of all the devices that we have. This is the APX. ASIA pupil expander, but it's a bit bulky device. It's a double iris hook. This is the Expand NT iris speculum. Again, it's got a biplanar device, and it snags the incision. It's difficult to insert and remove, a bit traumatic. So they put it through a injector, which kind of helped a little bit. but then again, still it's a bit jerky and not so controlled, so really wasn't so really so impressive. And this is the eye ring which has been there, but still a bit bulky. The vertical profile is quite a lot, 1.4 millimeters, and that where the corners rest is the mid-peripheral antechamber, where the AC is going to be pretty shallow. It's going to be 1.53, 2 millimeters anyway, and that would be a touch and go. This is the Canabrava ring, difficult to use. Again, it's a PMM device, has specific indications, can't use it universally. Then we come to the BHEX pupil expander, which is what we've been having in the last 2 years over here in India. It's a hexagon with notches and flanges, alternate flanges being tucked under the pupil margin, and the notches engaged to the pupil margin, which provides pupil expansion. So we'll skip that. Yeah. So how it differs from the Mulligan ring or the eye ring is that there's an entirely new concept. The device is in a single plane. It's a very thin device. It's 0.075 millimeters. While the Mulligan ring or the eye ring or all devices are biplanar devices which engage the pupil margin by the cup-like feature on the side of the device. Here, the entire device is in the same plane, and the iris kind of bends at the notches. So the iris can be bent harmlessly and reversibly, and that makes the insertion and removal of the device very easy, because that's a single plane device, so it walks in and walks out of the incision. A few pearls with the BHEX. I would urge you to watch videos. There are plenty of them on the YouTube, instruction videos as well, because the device looks so simple. It's no rocket science, but when you start off, you may have a little bit of a learning curve, so watching a few videos would be useful. It's very important to keep the anterior chamber slightly shallow. The standard protocol is as soon as we start the case, we inject a lot of viscoelastic and inflate the anterior chamber to get a slightly wider pupil, but that can be counterproductive because the iris gets plastered. So overfilling pushes the iris against the lens capsule, and that reduces the space for tucking the flanges. That works for all devices, even iris hooks. So when you push viscoelastic, the iris is getting plastered. So it rather serve better to use a bit of viscoelastic under the pupil margin to lift it off a little. So that keeps room for your iris hooks or Mulligan ring or eye ring or the BHEX. So whatever you use, you need the bowing of the iris. So this is how we do it. A little bit of viscoelastic in the central area so there is no touch over there, and then a little bit of viscoelastic under the pupil margin. You could use anything, HPMC. If you have sodium hyaluronate, that's better, but HPMC works as well. So if the pupil is smaller than 4 millimeters, I would recommend for whatever device you use a bit of controlled bimanual stretch, because especially if they are a rigid pupil, that would give you a cosmetically good pupil, because the purpose of using a pupil expander is not to tear that sphincter, but to keep that pupil in an expanded state so it does not come down. So let the tearing be done in a controlled manner. So how do you differentiate between a rigid pupil and an elastic pupil? There's a very simple test. Once you've done your paracentesis, before you do your main incision, just inject a little of BSS or ringolactate, whatever you're using, through the side port, and watch for that pupil expansion. See how this works. Done the side ports, and I'm just injecting that BSS over there, and you see that pupil expand. So this is an elastic pupil. This will allow you to get that pupil to 5.5 with your pupil expander without damaging the sphincter. This is another case where you have that expansion. Now look at this one. Pseudoexfoliation. This is not going to budge. It's about 4.5 to 5, but I'm not going to get it more than this. So, and this, of course, it's impossible. So you can inject sodium hyaluronate, you can inject Helon, whatever you want, but it's not going to kind of move. So this needs to be stretched, and we can do a bimanual stretch in a controlled manner so that we have about 4.5 pupil, and then you can use a device, iris hooks, whatever you want. That gives you a cosmetically good pupil the next day. So the take-home message is, unlike the elastic IFS pupil, the rigid pupil is a fibrous ring, and you can't expect a fibrous ring to stretch. So you'll have to tear it. Rigid pupils are better stretched to 4 to 5 millimeters before placing any device. A limited bimanual stretching would produce controlled sphincter tears and give you a cosmetically good result. A bulky pupil expander may stretch the pupil, but will produce uncontrollable tears and is unwieldy. That is a trade-off you must understand. BHEX is not a device which you can use to tear the sphincter. So let's look at this another case with the uveitic eye. So I released the synechia, and then I tried to remove that membrane, and still we could not get that pupil to a size which was good enough for me to use the pupil expander. So we went ahead and did a bimanual stretch. And you will see I'm not stretching it from limbus to limbus or angle to angle. I'm just stretching it to that 5 millimeters so that I don't create a cosmetically bad pupil. And then we go ahead and use the BHEX pupil expander, and we have a fairly good pupil to go ahead and do the phaco surgery, and at the end of the surgery, we would have a nice round pupil. We recommend only the BX 23 gauge forceps. It's got a particular design which is ergonomically suited for this device. If you're using the BX, I would recommend you to use. I recommend that you use this forceps, and this is how we do it. We tuck. In the first pass, we take the device and place it on the iris. It's important not to be impatient and tuck the flange in the first pass. You leave it on the iris, and then you start tucking, because if you tuck it in the first pass, if you tuck the first flange, then the device gets into two planes, and that becomes difficult to manage. Fixation of the globe with the side port instrument helps a lot in manipulations. You have a control, especially if the eye, you can rotate the eye if the side port is not accessible in a deep set eye. Now, the biggest advantage of the BHEX is in a case where you already have an open capsulorhexis. So here what the pupil has come down halfway through in the surgery. Now using a Mulligan ring or eye ring is very difficult in these situations, because you have a very high chance of engaging the capsulorhexis margin, and that could be a disaster. So here with the BHEX, you just need to inject viscoelastic on that anterior capsular rim, lift off that iris, and as you tuck that flange over there, you have direct visibility of whether you're engaging the capsular margin or not. And when you advance that flange to the periphery, you have instant confirmation that you have not engaged that capsulorhexis margin. There could be nothing safer than this, and the notches are staring at you. So you cannot, I mean, even if you face a little resistance, you come back and again disengage and go back. So once you have done that, now you have a comfortable pupil size to deal with the rest of that hard heminucleus. The BHEX gives you a 5.5 pupil, which is pretty good to do any kind of surgery. Now, it's very important not to dislodge the BHEX, or for that matter, any pupil expander, while you're doing your manipulation. So remember, chop the nucleus into very small fragments, at least 1 or 2 small fragments, so that you have enough room for the rest of the thing to come out. And the trailing haptic, attempt to deliver the entire lens into the bag, especially the trailing haptic. And if you can't do that, there is a way of dealing with it. You push the trailing haptic optic junction in such a manner that the leading haptic optic junction flexes against the equator of the bag, so that this clears the pupil margin without touching the pupil expander or the pupil margin. Otherwise, you're going to dislodge it. That works for any pupil expander. I'll just show you how it's done. So this is just half a minute more, Shraddhanshu. So that's the trailing haptic goes in one go. That's the best. If you can't do that, this is it. So my trailing haptic is going to be left on the iris, and the standard idea is to push it down. Now, if you push it down, you're going to take that device into the bag, and that's going to get messy. So now what you do is you engage it, and you want to push it, flex it over there, and not actually take support from the, you're not pushing the pupil margin. You clear the pupil margin and then take the trailing haptic down. So you need to be a little fast over here before that trailing haptic kind of completely unfolds. And removal of a pupil expander has never been so easy. Just disengage 2 notches on either side, and you can just, the trailing notches just disengage spontaneously, and it just walks out of the incision. And the best thing is it can be removed through a 1 mm side port. And that's how we do it over here. Let's see, we just inject a bit of viscoelastic, hold that with the 23 gauge forceps, and disengage it, like I said, and that's it. You disengage 2 notches on either side, and you just draw the device out. It walks out through a 1 mm. No device in the history of ophthalmology has been able to do that. So if you have a tight situation with IFIS, this could be a very wonderful device to use. These are a couple of publications in the IJO, December 2017, and in the Journal of Cataract and Refractive Surgery in 2014. Thank you very much for your attention. Thank you, Shraddhanshu, for this opportunity.
Thank you. So we are lucky that the fellow who has devised the techniques, the Indian technique, we were using balloon ring, costing 7,000 rupees. Is the ring available
Now it's
in India?
11,000. Now Mulligan ring is 11,000 rupees.
11,000. Is ring available less than 2,000 rupees? No financial interest. You can get it from Joja Surgical, from Calcutta. No, both. Any question regarding it?
No, I have a financial interest. I disclose that.
Yes.
But though I'm not making any money yet, yes, I have a future financial interest.
Because we are using this ring very well.
Thank you, Joey.
We
Thank
can
you.
reuse it.
Very kind words. Thank you.
So, any question to him till we are
Yeah,
ready
because
with
I'll be
the-
running away, so
Dr.
any
Inder?
questions, I'll be happy to answer.
Dr. Rajendra is very famous for, you can come here and answer the question, any question.
Chalo, thank you.
Dr. Rajendra is known as a terminator nowadays. He has developed a very good technique of dividing the hard nucleus. Problem is phaco is the hard nucleus for the any new surgeon. So he divided very new chopper and very good technique He will tell in 10 minutes time how you can divide the hardest nucleus by simple technique, very safe technique. We have used it, it is very successful.
Good afternoon, friends and ladies and gentlemen, and thank you, Dr. Satanshu, for giving me this opportunity to be here with all of you. The topic which I am going to talk about is terminal chop, an easy technique to crack and break the difficult hard cataract. Friends, we know that these hard cataracts have always been a challenge to all of us, and the challenge is primarily because of the following reasons. Because these hard cataracts have very weak and fragile capsular bag. They have an absence of protective epinuclear layer. There is a paucity of cortex. The capsulonuclear adhesion is another problem because since there is no cortex, no epinucleus, so the nucleus may adhere to the capsule. So you may have adhesion with the capsule. There is a laxity of the zonules. There is a compromised cornea, and many a times non-dilating pupil or the pupil coming down during the surgery. So creation of rhexis is one of the very important points because in these hard cataract, your rhexis has to be correct. It should be complete. It should be of sufficient size so that the manipulation of the nucleus becomes very easy. If you don't have the large rhexis, then it becomes very difficult to manipulate the nucleus. Your hydro procedure should be complete, and if at all, if the hydro dissection is not possible, then just leave it and you can rotate the nucleus later on. Because pushing a lot of fluid with the adhesions there, it may rupture the posterior capsule. You must use soft shell technique. Your visco injection should be much better, and the soft shell technique you all know. And your phaco settings have to be correct and appropriate for the cases. Looking after these challenges, but what I think is the most important challenge in these hard cataract is breaking them down into full thickness free segments. So this is the most important challenge. Unless you break the nucleus into full thickness free segments, the surgery would become prolonged manipulation, a lot of manipulation. You'll have to use a lot of phaco forces, a lot of phaco manipulation. So that could be very deleterious to the adjacent structure, especially cornea and the posterior capsule and the iris also. And it's very important to break them. The current surgical techniques, whether you use the original techniques or you use the hybrid techniques, what happens, we get into using multi-stroke drilling, trenching, grooving, creating. So all these things would lead to a lot of use of phaco forces in the anterior chamber, very close to the corneal endothelium. And the manipulation which we do is very close to the posterior capsule. If you are handling the nucleus at the center, that is the hardest part of the nucleus, and then you have to drill it, like you have to do the trenching of this kind, like which would need a lot of phaco forces. And using too much of phaco forces, you know, the status of the cornea may get disturbed. And going very deep, very close to the posterior capsule, you may hit the posterior capsule and land up with the problem of the PCR and all. So and then forcibly splitting the nucleus without having crack. If you split, because you do the trench and then you try to split. And this splitting force actually like this, like if you are splitting without having any drill or without having anything in this and you try to split these nuclei, increases the risk of injury to the supportive structure of the lens. And then we'll end up with these complications. So if you have to deal with the hard cataract, your technique has to be very easy. It should be safe. It should be simple, swift, effective, with minimal manipulation and least traumatic. And the most important is it should be consistent. It should work on each and every case. So I'm going to talk about which is called as a single stroke crack and break hard cataract with terminal chop technique. And the device which we use for this technique is called as a terminator. So these are our publication in various journals, and recently this technique has been included in ASCR's teaching program, and which is like one of the very important point, for this technique to be included there. So what is terminal chop technique? Terminal chop technique is a crack and split. So this is the point. You crack the nucleus first and then split. In other techniques, what we have been doing, we split to crack. So there is a lot of difference. Here you crack it first and then split. You can see here what I'm trying to do is I'm just holding the nucleus at the equator, just within the equator, draw it a bit, hook the terminator and crack and then split. So with this method, you can crack the nucleus into 2 complete pieces. So that is the most important thing. And the depth of the crack is full thickness. So you get a full thickness cracking of the nucleus. You can see here the second crack of the heminucleus. You can crack the nucleus accordingly, the hardness of the nucleus you can crack into 4 pieces, 2 pieces, or 6 pieces. See here, draw it, hook it, and crack it. And you can see the cracking is full thickness. You can see the glow behind. So this is the beauty of the technique, like you get a full thickness crack, and if you get full thickness crack, then you can very simply draw them on the phaco probe, with the phaco probe and emulsify with the proper settings of the emulsification, because you don't need too much of high phaco forces, high energy also. The important point, as I have told in the beginning itself, is like correct and proper size of the rhexis. So this is very important. You must get at least 5.5 to 6 millimeter of rhexis. In any case, any hard cataract, if you are dealing with a hard cataract, your rhexis should be larger, a little larger. It should not be small. So then your handling of the nucleus becomes very, very easy. Now this is the second case you can see here, a calcified nucleus. You just hold it at the equator, impale from the center, hook it, and crack it. See the cracking, the kind of cracking you get. So this is what you want in these hard cataract. So for that, what you have to do is like the vacuum settings should be around 350 to 450. Flow should be around 25 to 35. Phaco power, not too high, around 40% is enough. Your bottle height should be around 120 to 140 centimeter. And the tip, you can use any tip, but it should be either 0 degree or 15 degree, because you don't need too much of bevel to hold the nucleus. And you can see here the holding. The moment you enter this device into the nucleus, it cracks the nucleus. So you have a complete crack in the beginning itself, and then you split the nucleus into 2 complete pieces. So this is how you can split. And the splitting becomes very easy, and it's full thickness splitting. So the question comes, how do these nuclei crack with this device? The unique physical property of these brittle hard object has been described by Griffiths long back, somewhere in 1920, one of the physicists, very great physicist. And what he said was, like, any solid hard material, they are stronger in compression, but they are weaker in their tensile strength. So what does this mean? This means if you want to crush, cut, chop, sculpt, or break without having a crack these hard object, it will need lot of forces, lot of energy. But at the same time, these hard objects, they crack very easily without too much of forces. So this is the basic of this technique, like this has been published long back. This is how it cracks. You don't have to do too much of forces for cracking these hard objects. So for this, we devised an instrument which is called as a terminator, which is actually designed, created, and applied with the principle of classical simple machine. So you all know classical simple machines. The 6 classical simple machines which we have been taught during our primary education. And one of these simple machine is called the wedge. So you can see here, this is the wedge. And these wedges are used to separate 2 objects or induce crack or fracture an object into 2. They are commonly used. So a lot of wedges being used in the factories and other purposes. So why it is very important? See the wedges, what the wedges does. Wedges changes the force of direction. A radial force, like if you're putting a radial force is converted into a transversal force. So this transversal force works for cracking the nucleus. So that is why the wedges are used for separating and cracking these hard objects. And secondly, it increases the amplification of the force, like it improves the amplification. You put a little force and it is amplified by that instrument, wedge. So that is why wedges have been used in many purposes. So what we did, we actually incorporated this wedge design into the tip of our chopper. So you can see how we did. So this is the wedge which we incorporated here. So what we did was the tip of the wedge, that is the apex of the wedge, is the inner edge of the chopper, and the base of the wedge is the posterior surface of the chopper. And this chopper actually So I don't call it as a chopper, I call it as a cracker basically. So you can see this is how it comes out. So it has a apex inner side and the base posterior surface which is flatter. So when this device enters into a hard object, it gives you a cracking effect, a cracking force. So this is how this looks like. And we created different angles of the wedge. There are different angles of the wedge, but the 75-degree angle of wedge works best for the hard cataract. So we devised 100-degree angle also, which works for the soft cataract. The conventional chopper which we have been using till now, they don't have wedge effect. They have hardly less than 20 degree of wedge. So if you have a wedge of less than 20 degree, this will not produce any transversal fracture force. They will not produce. You have to just drag them. You have to drag these conventional chopper through the hard nucleus. It doesn't give you a cracking force. You have to cut it. And you know, cutting hard nucleus is very difficult. You can't cut it. So that is why we get the problem in using these conventional chopper and getting the fracture of the nucleus. And this is the overall design. Just 1 minute, that's it. This is the final design. It has an olive tip. It's a blunt tip. So if you're hooking the nucleus, there is no threat to the posterior capsule. So you can just hook very safely. And the rest of the features you have already seen. And how it works, you can see here in this video animation. The nucleus is held with the phacoprobe, drawn a bit, and then you hook it very safely. And the moment you draw this device into the nucleus cracks. So this is how you get the cracking effect. And then once you have a crack, and then you can split the nucleus very safely. So I'll just show you the last video. So this is one of the very, very hard cataract, which is more than grade 6 cataract, like black cataract. Does this instrument work in this situation also? Like you can see here, very simply, you can crack even these rock hard cataract also. So what you have to do is impale the nucleus a little distal from the center. Your phacoprobe has to be superficial, don't go deep. Superficial, then only you'll reach the equator, and then hold the nucleus just within the equator, a millimeter or two within the equator of the nucleus, not the cataract, nucleus. Then you draw the nucleus, hook it, and crack it. And then you get a complete full thickness cracking of this. See, you can crack even these hardest of hard cataract with this device. See the another crack? Once you created the heminuclei, then you hold one of the heminuclei and crack it further into 4 pieces. This is the another crack. I'm going from the other side. Hold the nucleus superficially. So this is important point. Hold it, break it. Now you have a complete full thickness pieces. Go for the another crack of the, to make it another piece, 4 pieces. You have to be very slow in these hard cataract because you have a very weak capsule. So go for the another crack, hold it, impale it towards the equator, hold the nucleus just within the equator, draw it, hook it, and crack it. So now you have a full thickness pieces. And these pieces, now you can draw them on the phacoprobe very simply. The important point here is like you are not putting too much of stress. So your zonules are always safe. There is no stress on the zonules. You are not working very close to the posterior capsule, so there is no threat to the posterior capsule. You are not using too much of phacoforces, so your cornea is absolutely safe. And if you do with this technique, you get a crystal clear cornea on the second day itself, and you don't have to bother for the complications and all with this technique. It's very, very safe, very simple technique, and it's repeatable, it's reproducible, it works in each category of cataract. You can use for the grade 1, grade 2, grade 3, 4 cataract also, and it works best for the hardest of hard, the grade 6 cataract also. Thank you very much. Now this is being produced by the Epsilon India and Epsilon USA. So it's being marketed in USA also now. Cost now it's around 2,000, 2,500 rupees.
It is available here in this Epsilon stall hallway, and we have tried it also because we have seen his videos almost 1.5 years back, and it is really successful hardest cataract, very safe. Yeah, Rohit.
Yes. You have seen, because the cases I showed was hardest of hard cataract, rock hard cataract. So any hard cataract, the nucleus, it means the nucleus is slightly shrunk. You don't have these intumescent kind of cataract. The hard nuclei, generally they are slightly shrunk and very hard. So once you do the hydro procedure, free the nucleus, you have enough space, no problem. And here in this technique, like actually, unlike in a peripheral chop, where you blindly go under the capsule and go to the equator of the nucleus, and then try to hook it or try to put the chopper at the periphery, which is very dangerous, like which I was also doing in the beginning, but I found so difficult, so many complications. But here in this technique, what you are doing, you're holding the nucleus at the equator. When you're drawing it slightly, you have to draw it just hardly 1.5 millimeters. You're just slightly drawing. The nucleus also makes a rotational movement while drawing it, if you are holding it at the equator. If you hold at the center, then it will not rotate. If you are holding at the equator, drawing makes a slight rotation. Slight rotation gives you a complete visualization of the equator of the nucleus. So it's a complete under visualization technique, like you are visualizing the equator and then hooking it. So you have enough space, enough positioning, enough time to position the chopper around the equator, and then you have to draw it and crack it. See, the point is, this technique is broad. I'm not saying it's the replacement of the vertical or horizontal chop. This technique is another tool to use where you find problem. If you are not conversant with the vertical or horizontal chop, you are not very fond of this technique, use this technique, you will find 100% simpler and easier to use this technique. That is why I'm trying to say.
Thank you. Now we have another stalwart, the Rohitam Prakash from Mr. He is speaking a very important topic that we face normally in every hypermature cataract. How I retrieve the extended axis.
Thank you, Dr. Satanshu, for the opportunity. Well, the topic is CCC rescue and anterior capsular tears. Well, when the rhexis goes astray, Little's maneuver comes to rescue. Now, what happens in this is, yeah, the video is not coming here. What
Video.
Just 1 second.
You take it.
I just want to titrate it here also, stop it.
चल रहा है, video चल रहा है.
नहीं, यहाँ I want
अच्छा,
to
वहाँ
do
नहीं
it.
आ रहा.
ये क्या किया आपने इसको? नहीं, वहाँ हर
Advantage or advantage in that this
हर
chop
जगह
is
ठीक
also
आता है।
that it is not very
क्या
sharp.
किया इसको?
So chance your damage to the use a capsule or posterior capsule or nucleus is not
ये
less.
नहीं आना
It is
चाहिए।
blunt.
Current slide में ये क्या किया?
Blunt. Normally in hard cataract we use
पर यहाँ जब मैं
sharp
चाहूँगा,
chopper.
मैं उसको रोकना चाहता हूँ।
That's why we have to be very careful. We are going to peri without visualization. But here it is blunt tip.
ये चला।
So it is very safe. Mic, right ना mic ले ले. जब तक video नहीं चले.
ये चल रहा है, अब उसको रोकूंगा कैसे? How do I stop it?
How deep should be the probe deep within, phaco probe within, before separating
क्या
it
किया?
out?
I told very clearly because showed the video also. The most important point is like you have to reach. This is not
ये
working.
हर जगह चल रहा है।
The most important point is like you have to reach the equator. See the cracking goes. If you have to tear a cloth, how you will hold it? You can't hold it like this.
Current slide.
You have to hold it close,
क्या
and then only you can tear it. The same principle work here, because if you have to crack or tear the nucleus, you have to put both the instrument adjacent at the same point. So to put the instrument at the same time, you have to reach just within the equator. The people keep asking like how you can go to the equator. It's not the equator of the lens. Equator of the lens is quite far where the zonules are there. It's the equator of the nucleus. So nucleus equator is quite within the capsule. And the edge, it's almost at the edge of the capsulotomy if you're making 6 millimeter capsulotomy. And to hold the nucleus at the equator, you have to go somewhere because you know the structure of the nucleus. The nucleus is flatter anterior surface and it's very convex posteriorly. So equator is almost parallel to the anterior surface. So if you penetrate the phaco probe deep, you see the edge, hook it. Once you are able to hook, 100% you will be able to crack the nucleus. It's only hooking which is very important, holding and the hooking, which you have to learn, and it takes hardly 5 to 6 cases to learn this technique. Another important part, because you have brought this very nice point, because in this technique is a cracking and splitting, as I said in the beginning. It's not a chopping. In horizontal chop, what we do, we hook it, and then you have to drag the chopper up to the phacoprobe, which is at the center. You have to cut it, which doesn't happen in a very hard cataract. You may be able to do with grade 2 nucleus or 3 nucleus, but with the hard cataract, it doesn't happen. You have to, dragging becomes very difficult, and the nucleus start rotating and you don't get the full thickness. Here, you don't have to drag it. You have to just hook it the moment, because it's a wedge. It's the wedge. The moment the wedge enters in the nucleus, it cracks the nucleus. So you got a crack in the periphery itself. And that crack, like any stone or you crack a glass, the crack created at the equator, it automatically traverses to the center to the equator on the side. You get a complete cracking automatically. You don't have to crack it then further. Then you have to just split the few fibers which are remaining, split it, and you get a complete 2 pieces.
So Rajendra, next discussion will be on T. The same question you were asking, we were asking 1 year back. We have the same queries, and he is very gentle to remind us and make us master of this surgery. So you can, he is with us, no problem, you can ask anything. There is some change, there is a problem with Rohit. So I am taking the topic, this is the another important topic, is the posterior polar cataract. We all face our differential diagnosis, we all know this is posterior subcapsular cataract, we have to differentiate. There are 10, 11 tests I will tell you. First is preoperative evaluation. There is one-like appearance. Simply differentiated with posterior capsular cataract if you, posterior subcapsular cataract, if you carefully examine it, it is raised from the surface. Tip number 1. Tip number 2. You have to remember, in 33% cases, there is a posterior capsular defect. You have to keep in mind, posterior cataract, we have to be very careful throughout the surgery. 11 tips you follow, 110% guarantee of success. But even then you fail, you can manage. Tip number 3, capsulorhexis should be small but adequate size. Suppose there is a PC rupture, we can implant the lens in the sulcus over it. If it's too big, there will be no capsular support for implant of the sulcus. Tip number 4, no hydrodissection. Hydrodissection will increase the posterior capsular defect. So the hydrodissection should not be done. That's tip number 4. We should do, you see, if you do hydro, we have like this PC rupture. Then hydrodelineation, it should be very, very gentle, tip number 6. So hydrodelineation, so this is a cannula developed by one of my friends. If you do normally, fluid will go behind it. If you in the hydro, fluid will go behind the defect and will increase the defect. This is a cannula which has port on the side, not on the tip. So you fluid injected, it will go from the side, not from the tip. You see, the flow is from the side. This hydrodelineation with modified cannula, fluid is not coming from tip, coming from side, it will not go behind this part. So this is another tip, use this type of cannula. So this type of cannula, this is tip number 7, epinuclear shell. This shell should be removed the last because we know there may be defect. We have to keep in last. It will protect the posterior capsule. Tip number 7. This is the natural normal case. I want to show you one thing. There is a PC rent. We have already seen on slit lamp. If you make a beam on slit lamp, tilted slit lamp, you can find out there is a defect in posterior capsule. So we have find out there is a defect in the posterior capsule already existing. So we are very careful during our surgery. We have done small axis, adequate size, as I told you. Phaco is the safest in this type of cases, not the size here, because it will have less closed chamber. We need closed chamber. Adequate axis has been done. And a gentle hydrodilation only. We can do for multiple sides, 2 or 3 sides, no hydrodissection. That already we have done. Now, important part, most of the cataract posterior are soft cataract. So you have to that job. You have not to rotate the nucleus because rotation will increase the posterior capsule defect which is already there. We have to just divide, gentle maneuver because large PC rent is behind it. Just do a cut and soft cataract, you pull it in the center place. Phaco, you can see the power is only 10, vacuum only 10, bottle height should be less. So there should be, Partha please. So there should be no pressure on the posterior capsule. Because the nucleus, it is the normal time Phaco. So you have to be very patient watching it and doing it. Very slow. If you do finish a Phaco 5 minutes, you have to take 10 minutes. So parameter you can see very low. We are not pulling the nucleus. We are bringing the supracapsular plane over the iris plane, and we always have to keep away from the power away from the posterior capsule. epinuclear shell that is left, it is substitute for the posterior capsule. We have to remove in the last. This 7 tip we already discussed with you. This is the epinuclear shell. Because the parameters are low, so it is taking time in sucking. See, tip number 8. Whenever you remove the instrument from side port, always inject visco from side port. Chamber should never be allowed to collapse, otherwise you increase the PC rent. It is normal in every PC rent. You should not allow the chamber to collapse. Always inject visco from side port before removing the instrument from main port. Posterior polar plate is left for the last. We are removing it now. We are removing it now. Because we know there is a PC rent. So this posterior capsule remnant plaque, we are removing the last. Because now even if the posterior capsule rent increase, it will not affect our procedure. And always bimanual maneuver is useful in such cases because process is very slow. You can maintain the pressure. You see we have removed. Now what I want to show you, this is, you can see the posterior capsule defect. This was same size before the surgery. It has not increased after the surgery. We have not damaged the anterior vitreous space. So we have nothing disturbed, everything perfect if we follow the 10 tips. Patience, patience, patience. So this is the defect which was pre-existing. So vitreous faint. Now we can implant the lens in the back because there is nothing disturbed. The tips you should remember: correct preoperative diagnosis, small but adequate access, no hydro, gentle hydrogenation, no nucleus rotation, AC maintained, low parameters, low motion, and no panic. And sometimes you are not so lucky. Even after taking so much precaution, you are not lucky. Is a full video करना? So we have already taken every precaution. Small axis, no hydrodilation, dissection, hydrodilation done. We are everything we are doing normal. Never think you are God. You can do everything. The consent is very important post-polar care. You should get in writing for the patient. Complication can occur. I always take, that's why I am always safe. You see, everything. Before removing main instrument, we are injecting with viscoelastic from side port. Every precaution we are taking. Sound is sound. Sound gaya? Bhag gaya. Sound. See, what is this? Do not panic. Oh, what happened? My guy heard. Patient will get up. Sir, ठीक तो हूँ मैं. What we do? We say, wow, अरे क्या हो गया यार? सब ठीक चल रहा था. Normal reaction. Never panic. Keep silence. Staff को भी चुप. Take your time. Say God को याद करो. 2 मिनट में vitrectomy के instrument का arrangement करो. 5 मिनट लगेगा. Keep patience. But do not panic. Patient पूछता है, सर क्या हो गया? ठीक तो मैं. So do vitrectomy. Every anterior segment surgeon should know anti-vitrectomy. Everyone should know. We are teaching necessity area for last 3 years. Everyone should do. It is a very easy job. So we are doing anti-vitrectomy from the. You should not use the main port for anti-vitrectomy. You can make another port and do the anti-vitrectomy. Anti-vitrectomy is very easy. Nothing to. Every machine has got anti-vitrectomy. You parameters. Company man will tell you easy, no problem. So important point. Tip number 11. Always insert the lens in the sulcus and 3 peaks. When there is vitreous disturbance, never inject in the back a single piece. Keep your library. IO implantation, I have done this anterior chamber. Why? First, because now we have to align it in direction where posterior capsule support is there. So we have put in the anterior chamber. You see, it is AC. Now we are dialing the, where we have support, we are taking the optic in that direction. If you go directly in the sulcus, it might dislodge, some part may go in the back also. Now rotate it and bone there, then do optic capture. This is tip number 12. Optic capture, because of the stability of the lens. If we optic capture, then lens will be stable. Now again remove the whatever vitreous is there from the front. Always do vitrectomy in the wound area. Otherwise it will attract the infection. This is vitrectomy we are doing last in the wound area. And you see, important, these are small tips we should know what we have done. I will like to show you here. You see, यहाँ से हम we are inject hydro कर रहे हैं, but chamber is not allowed to coalesce even now. We are injecting fluid from side port. So chamber should had good wound hydrodilation should be done in last 2 steps. To take on matches, read about the subjects. Hydrodilation, not hydrodissection. And AC should not be allowed to collapse. Do not panic. This is an important topic I want to show you. Thank you very much. Now, so now we invite none other than Dr. Partha Vishwas, Chairman ARC. Everybody knows how good a speaker he is for IOL exchange. Very important topic, IOL exchange. It is again becoming very important nowadays because cataract surgery, refractive surgery, nobody wants it by 12. If there is a problem, halos, everybody wants to get to move the lens. So he will tell you how to move it.
Excuse me, sir.
Any question? Yeah, he's ready. Partha? Yes.
I was asking about the optic capture.
Yeah.
So since we put the lens, yeah. So are we putting the optic into the bag?
Optic inside. Partha वहीं से बोल दे मेरा throat is. How do you optic capture do?
Oh,
Actually, I am having problem with
okay,
throat.
fine. Optic capture, it's a very important technique. Now, for optic capture to be done well, the first thing is the anterior capsulorhexis should not be too large. It should just be adequate size, 5.5 to 6. And for this, I would really request you, all of you, to have the rhexis marker. Very simple device, but it gives that impression, and you can really make a good rhexis, more or less central, and not more than 5.5 to 6. So that's the first thing. So if you have got a good anterior capsule and anterior capsular support, then even if you have a posterior capsular tear, you can always get a good anterior capsular capture. So you have managed your posterior capsular tear, whatever maneuvers you have done, everything is settled. The vitreous is out of the way, you have put in the lens, and then once you have put in the lens, then the haptic, and what lens should you put in? It is the multi-piece lens. Multi-piece lens always in the sulcus, absolutely sir. 3-piece lens always in the sulcus, single-piece lens never in the sulcus. So once that is done, then once you have rotated it and it's nicely in the sulcus, then all that you have to do is to tap on one side and see visibly that the rhexis is coming on top of the intraocular lens. Again, tap on the other side, the rhexis will come. And then the rhexis, anterior capsular rhexis, will form something of an oval shape. And then you know it is stable, but then also you should move the lens a little to think of the stability. This can also be done even if there is some amount of zonular dialysis and you put a CTR also in the bag. So just to...
that matter. Because oval rhexis, if it is done, gives you the advantage of having a longer, larger rhexis in one half and a smaller in the other. And that makes optic capture easier also, for that matter. Yeah. 5 mm, yes. 4.5 you can have in one, and you can have maybe 6 in the other, or 6.5, whatever it is.
So there are other types of captures also, retro capture, where the lens is in the bag and then you capture it on the anterior capsule, you push it up. All these are possible, but the best capture is, of course, the lens in the sulcus, 3-piece lens, and you are tapping it, and the anterior capsule envelops it. That is the best. So we'll just talk about and spend some time on IOL exchange made easy. So what are the times that you feel that, yes, an IOL has to be exchanged? Of course, if it is a surprise, you have an incorrect biometry and leading to a gross refractive surprise. Again, we all know that we should wait and not be on that first post-operative day trying to jump to conclusions. Patient might not be able to see, your optometrist might say, this, sir, the cylinder is very high or the refractive error is very high. Let it settle 10, 15 days. Be sure that it is such a refractive error and it is stable, then only think of the next step. There are at times that even after counseling and you have thought about neuroadaptation, you have counseled the patient, and even after months, the patient might say that he is very unhappy with the surgery despite a good surgery. He's having optical aberrations, and that at times is a position where you have to exchange the lens. Again, of course, when it is a subluxated lens or a dislocated IOL which has opacified, causing visual problems, and which we face now and then, but very often in our theaters, is when you have pushed in a single piece IOL or a three-piece IOL and it has gone in and it has damaged. So the cartridge or the plunger has damaged the IOL and you have to retrieve such a situation. So let us look at a few techniques, and this is mainly a video-based talk that I have thought of. And look at this, we have damaged this lens, and with the lens damaged, the haptic has been severed, and what we have to do is to get this IOL out. So the first and most important thing is this, that you have to support the IOL before introducing the scissors. Okay, so if you support the IOL well from the far point, then only you will be able to cut. Otherwise, the IOL will go on shifting its base and go on across. Then once you have cut, you don't need to cut. In this case, I think we cut right through. You don't need to cut right through at all. You just need to go right up to the center. And once you are at the center, then all that you have to do is to get one part out and just pull it out. So what happens is the half-cut optic swivels out. So once it swivels out, it is out, and you do not need to increase the size of the incision at all. Now, why I showed this technique is not the best technique. Now, when you have a scissors that you're operating vertically and you have an intraocular lens that is horizontal, then what happens? It does not match to the incision. You have a vertical scissors, your incision is horizontal. So what you're doing is you're trying to cut. You're opening the lips of the scissors, and thereby you're losing viscoelastic. And this all the time keeps on happening, and then you're scared, you're causing harm to the endothelium, and things might go wrong. So what can be another technique of explanting? And this, again, if the lens has already got into the bag, what you can do is to flip the lens up like this, and once the lens is flipped up, then you push in high molecular weight viscoelastic, supporting the posterior capsule. The posterior capsule at no point of time should come up or surface. And then when you have got it into the anterior chamber, then you are cutting it with scissors like this. Now this scissor is the right scissor. This scissor to cut in and to go just about half in. So this is the right scissor, and as you can see that just half a cut on the optic, and you're holding the removal with two forceps, hand over hand, and it comes out. You do not have to increase this incision beyond 2.8 millimeters. However, if you think there is too much of a struggle that is going on, do not let ego come into the way, and then you can always increase the size of the incision, have a very safe delivery of the intraocular lens, and then if it is not hydrating well, you can always place a suture if it is required. So all these techniques, because it's an extra technique, we do not want to endanger neither the endothelium nor the posterior capsule. Let us look at this, the third technique, and this is a very important technique. See, we have this damaged IOL once again, and this time what we are doing is we want to flip it over so that it is in a vertical axis. So this is vertical. My scissors that is going in through our horizontal incision is horizontal. I'm supporting this with the end with a Coughlin's hook. And what I have done is I've just simply cut across, half across. I've put two incisions or two cuts, and with these two cuts the lens can absolutely come off. And these are special scissors which can be bought from many manufacturers, and once you should have these special scissors because they are strong ones, they are serrated ones, and the ordinary vanners at times do not do a good job. Now I have to show this wonderful video which has won the best in ESCRS, and this is by our colleague Dr. Arup Bhaumik. And in this video he shows how an intraocular lens can be explanted, and he has a snare. It's quite a long video, I'll just tell you how it is done. He has a snare in place. The snare engulfs the whole optic, and once the optic is snared, he just pulls it into the cartridge through the snare, and the whole lens folds in. And this, of course, he has shown it demonstrated with the single piece Acrosoft lenses. So now going on to some other situations, and we need at times to explant an ICL. Would anybody want to see an explant of the ICL? Or
Yeah.
if you're not interested, we'll go on to. Are you?
No,
Huh, sir? So again, ICL is an intraocular lens, so I just thought that if there are some people interested, we can see an ICL explant. So this ICL explant again is not so easy as you would think, but it can be done very well. All that you have to do is the ICL is there on the crystalline lens. The crystalline lens is a virgin lens, and you have to remove this lens for whatever purpose. So here is the time that you have to put in dispersive viscoelastic both between the ICL and the crystalline lens, as well as to protect the corneal endothelium. And as you can see, what I'm doing is to rotate the lens and trying to get a grip of this ICL with the special forceps that is supplied by the manufacturer. And this forceps is very important because it has to grasp but not to tear. If it tears, then it will not come out. It has to grasp well, and again this whole ICL must fold in. So as you can see now, it is folding in and out it comes. But if the right technique is not utilized, then it might fall short and you might have a problem. At times the iris might come into the way and you can have iris prolapse and things like that. So this was an explant and an exchange because it was a wrong diopter ICL that was implanted. So another small video, I think this one part of the video unfortunately was not working, but what I would like to show is here again IOL that went in, a dropped IOL, which can be extracted up. The VR surgeon has to do this job, and a good vitrectomy, seeing all the periphery for any breaks, taking the IOL up, either removing this IOL and replacing it with either a glued IOL or sulcus fixated IOL. And
He's covering sulcus.
huh?
He's covering sulcus fixated.
Okay, fine. So that Srinivas will show. So this again is an important part. Now, whenever there is a surprise, a refractive surprise, then what you can also think of is not explanting, but adding on something. So here comes the importance of having a sulcoflex. Can I take just 2 minutes?
Ah, very important. This is very
So
important.
the sulcoflex lens is a lens that comes into and is placed in the sulcus. So you have the original lens that is there in the bag, and it has to be there in the bag. Otherwise, do not think of or attempt a sulcoflex lens. At times, there's a little bit of adhesion, and you have to see that the adhesion is cleared off, because the sulcoflex is going to go into the sulcus, and it is a 13.5 to 14 millimeters lens, and it has a very specific haptic structure. And we said that a single piece lens should not be placed in the sulcus, but this is one lens which is single piece and is supposed to be placed in the sulcus. So what do? We have to fold this lens very well, otherwise, you might actually damage the haptic of the lens. So once nicely folded, you have cleared up the synechia, you have placed dispersive viscoelastic in the anterior chamber, you have done a good fill so that you have a good space to go in, and then this sulcoflex lens has to be gradually placed inside the anterior chamber. And once placed, the haptics go into the sulcus and occupy the place, and it is a lens that serves a purpose. Any spherical surprise can be taken care of. Cylinder can also be taken care of, and these are expensive lenses, so you have to be very sure of the biometry of these lenses. So it just has to be tucked. It's not a very difficult situation at all, and it can be done very well. Thank you very much for your
Thank you,
kind
Partha.
attention.
These sulfur lens is only problem is the cost. Otherwise, they are really very good for us. We are not respond. We hope Indian company will make it future.
Sir?
Partha, idhar se.
Yeah, so what I did actually, I cut it in two places, but only half. I did not want to take out a sector. It was just to squeeze in the IOL through it was a 2.2 millimeter incision, sir. So I thought that if I cut it into on two sides, then it will be easier for the rest of the optic to come out.
Its problem in hydrophobic lens actually. In hydrophilic lens is no problem. We can cut half and we can cut less than half. We can make triangle. Problem in hydrophobic lenses. In hydrophobic lenses, you have to fix from the side port very positively, and you have to go and through up to the 6 o'clock, 12 o'clock. Otherwise, it will not come out. I have a video. If you have time, I will show you hydrophobic lens. We have to go. I will show you hydrophobic. I have divided 5 or 6 pieces. I have removed from 1.8 even from.
Manufactured imported from Epsilon, but even other companies are making it. And you will see that it has thick, teeth in between. It's a very useful scissors.
Yeah, it is IOL cutter. It is available with Indo-German here. It is available with Anchor Surgical here. It is available with Joja Surgical here. It is available with Epsilon here. I have purchased 7 yesterday. Yeah, because
For the next course, sir.
no, actually, not for me. I have been demand for because I have presented this presentation. I presented several conferences recently. So they told me if you are going there, purchase, because this cutting capacity goes on after 3 or 4 cases. I use the Joja, the cutting capacity goes after 3 or 4 cases. But this is very useful nowadays. 2 or 3 I have to keep in my OT for myself. I have taken yesterday from Indo-German also. I hope it will be good, but very costly.
Yeah.
They are giving 17,000 rupees. And and Joja, they are giving 4,000 to 5,000 bargaining.
So we
It's a
move
very
on now.
important topic.
Yeah.
Yeah, thanks.
So, how many of you are sure when the capsulorhexis runs away? When it runs away, the maneuver which is followed is basically, in this video, as you will see, the capsulorhexis is being done in the routine way. The capsulorhexis flap is being formed, and suddenly you realize that it has extended to the periphery. I cannot stop it because there are some issues. Now, what do we do now? We deepen the AC. After deepening the AC, the next thing which needs to be done is we need to make the flap within our control. And how do we do it? We make it slightly concave. Then we go as close as possible to the end of the flap and pull it in the direction in such a way that the vector forces, resultant vector forces, make it go that way. I cannot show it with the arrow. I would have been able to, but it is not coming. So this Little's maneuver is possible at certain conditions. But what should we do when it doesn't come back? Well, when it doesn't come back, we have an Argentinian flag sign. So my question, I see new faces in the sense those who have not been in North. How many of us have not heard of flap motility sign? Can I know? Or each one of you have heard? Oh, so that's a good number. So that will serve my day. So now what happens is, when it goes away, what do? We are always in a surgical dilemma. What to do? So the next thing is, we should know what flap motility sign is. This flap motility is a sign of posterior capsule rupture in peripherally extended anterior capsular tears. If the flap, for that matter, these are the different types of anterior capsular tears, the pre-equatorial tear and the post-equatorial tear. Now the next is, what is happening there now? Is it okay now?
Yeah.
Yeah. We have complications when it extends to the periphery. We have to convert to manual extraction in 5% of cases, and we have seen that there is a nucleus drop in a good percentage of patients. There's always a surgical dilemma whether to convert or to continue with phaco, and we are already aware of the classical signs of these posterior capsule rupture. The problem with these classical signs of posterior capsule rupture are they do not appear instantly, and there is always a time lag for recognition of the signs, which varies according to the expertise of the surgeon. So here you will see that the flap is fluttering. So when this flap is fluttering, what does this mean? This means that it is pre-equatorial. And if it extends beyond the equator, then it would not flutter. Just see this animation, and in this animation you will see that the flap is fluttering and it is everted. A fluttering flap is indicative that it is pre-equatorial by all means. I hope for those who are new to it, they should, what is required is that they should just look at the flap. So why does this happen? It simply happens because of the fact that the end of the flap, I have to see there whether it is, end of the flap, there's a short arm. It becomes responsive to the fluidics in the anterior chamber. When it becomes responsive to the fluidics, it flutters. Had it gone beyond, it would not have fluttered. So that end point acts as a pivot around which it rotates or around which it flutters. Now what I would like you to do is, I would like you to see this video. In this video,
तुम लाइट बंद कर देना भाई, लाइट बंद कर दो जरा, लाइट बंद कर दो. Yes, yes, yes. सर पहले याद नहीं दिलाया आपने.
Yeah. Is the video working now?
Working.
Working, it was working? Sorry. I don't think it is. Yeah, it is working. Yeah. This is the Argentinian flag which is already there. Now I want you to focus on that flap. You would find that this stripe and blue flap is fluttering. So when it is fluttering, you continue with your safe phacoemulsification techniques, and you should conclusively go ahead with your phacoemulsification. Is it a new development? Well, definitely it is not a new development. Our focus has always been, here. It has never been here. So we just need to widen our field of vision, continue with the phacoemulsification, and you can see here during the cortical aspiration, it is still fluttering. So this fluttering should make you be convinced about the fact that it is pre-equatorial. And you can very well put an intraocular lens, because if the flap, with flap motility sign not in your armamentarium, you would not have known, you would have been in a quandary whether to put it in the bag or you should do some other maneuver. But if the flap is fluttering and it had fluttered, you can very well put the IOL in the bag. Now, what is the hypothesis with a non-fluttering flap? Usually what happens is there is a barrier between the high fluidic pressure in the anterior segment and a low pressure compartment in the posterior segment. Now what happens is, whenever there is a breach in that barrier, this is high pressure, this is low pressure, there is a breach, this negative pressure pulls it down. So when it pulls it down, the nucleus also drops, And when it gets pulled down, the flap also gets pulled down. And when the flap gets pulled down, it doesn't flutter. So this is what the hypothesis is. Yeah, here, when it becomes post-equatorial, it stops fluttering and it becomes inverted. Again, it is being repeated. It becomes flat and it becomes non-fluttering. Now, this, when it extends beyond the equator, there is a breach, as I already told you. There's a negative pressure here. There's a high pressure here. And with a big volume here, big volume, and anterior capsular tear gets pulled down. So that is conclusive of the fact that it has extended beyond the equator, and that is usually the end point of safe phacoemulsification. So these classical signs of posterior capsule rupture, they appear later on. So this appears the moment you find that it has stopped fluttering. Well, that should be the end point of safe phacoemulsification, and you better convert. Dr. Stanshu, it's beyond me. I'm sorry.
No, no problem.
It's beyond my control. So this is the end point. I'm just trying to show the end point of safe phacoemulsification. This is the end point. Now it has extended. Now I would like you to see a video. In this video, the resident is trying to extend to create a larger rhexis. In a process, what he does is this capsulorhexis extends to the periphery. You can see the flap, it is fluttering out here. He is doing his routine procedures. As the procedures which he is doing are continuing, the next step which he does is he tries to divide. Just see here. Suddenly what will happen? It has stopped fluttering. He should have stopped with phacoemulsification, inflated the bag, and done with the converting maneuvers. He, oblivious of the flap motility sign, he continued with phacoemulsification, and you can see the end point that it goes behind. So this is what the flap motility sign is. So you see that it continues, he continues, and we end up with a situation that it goes into the posterior segment. So with this flap motility sign in your armamentarium, it makes you feel what the end point of safe phacoemulsification is. It eliminates the dilemma in the presence of anterior capsular tear. It reveals the extent of the anterior capsular tear. Confidence, well, it brings in confidence for surgeons of all expertise. It prevents catastrophes, and conclusive for IOL implantation in the bag. Small things at times make a large difference. Thank you very much for your kind attention.
What seems to be small, for this he has worked for 3 years.
Yeah.
He had done a lot of research in the cadaver eyes. He has got presentations in internationally also accepted, and he got a prize also. So what seems very small thing, what keep is rotating on floating or not floating. But for that he has to do research for 3 years.
Yeah.
And the conclusion we have extracted in 5 minutes time. Thank you, Rohit.
Thank you very much.
तुम्हारी research हमारा फायदा. Now another stalwart, he will telling about the once everything goes wrong, how can we fix lens in the sulcus? Now Srinivas, ready? Any question to Rohit till now?
I think to
I would like to compliment Dr. Rajendra Prasad, because I have been presenting this for quite some time, and his questions have always made me go back and become vibrant. I'm trying to wait, I'm waiting for a question which will make me still vibrant.
nothing special, very simple question I have for you today. The two important things which I could see from the video is, one thing is always stain the capsule. So your visibility would be much better, like the fluttering sign. You can see much in a better way if you are staining the capsule. Make habit for every patient. Yes. So for the new especially, it's very important. Stain your capsule. Nothing happens. There is no complication of staining the capsule. Always stain. You will be much better during the surgery. Like you know where to take your phaco probe, how to go about, and if you have to see the fluttering sign, then it will be much betterly visible. Yeah. Okay. Yeah, I'm staining all the capsules. Now, second important point which I want to ask you is like this fluttering sign, if you have an extension radial, we call it a radial extension of the tear, like it's going in one direction. And what happens if it's a Argentinian sign of, kind of extension, like there is an extension on both the sides?
That was the Argentinian sign.
The last one.
The white one, the white mature cataract.
Yeah. So then where to look at the fluttering signs, like at the, which end?
Wherever you can find, wherever the flap is, it could be right, wherever it is turned around somewhere, you will find that it is fluttering. And it is very simple. You will really see it.
No, why I'm asking is because if you have an extension, radial extension from pole to pole, then you don't have the flaps. Then you don't have the flaps.
But still it will be doing there will be some motility.
The flap, the total movement will be there.
There will be some motility here and there.
Okay.
The other one will be down flat.
All right. Okay, third important point is like if once you see this fluttering sign at one area, what I've seen, because on two of the videos, the phacoemulsification was continued in that axis only. So ideally, like if you get a extension of the capsular tear in one direction or both direction, any direction, or if you start seeing the fluttering sign, your axis of phacoemulsification should change. You should not emulsify in that area. You must shift. Rather, you can make another port to start the emulsification from other direction radially. It should not be in a parallel axis. It should be a radial axis. You go to the other axis and then emulsify. Because if you continue the emulsification in that axis only, then definitely, because this fluttering sign would stop and the extension would go into the posterior capsule. Yeah, I know. I'm not saying you.
And this is the importance of recording.
Yeah, this
if you
is the-
record your videos, you can find out where we have gone
But
wrong.
yeah.
We could not find this because nowadays with all these better maneuvering, there is hardly an extension to the periphery. With all the stable chambers and things.
That's right.
When you know,
That's right.
when you know that you have to divide,
Yeah.
you have to separate, your separational forces have to be there,
Yeah.
your parameters have to be reduced.
Right.
So all those things.
Right.
So we were not having, so we had to go back
Yeah.
on all the videos. And then we realized, yes, there.
That's right. Thank you, Ravi, for the very, very nice presentation, and it was really, I think, helpful to the new residents and even to us also.
Good afternoon, everyone. I would like to thank Dr. Satanshu Mathur for giving this opportunity. In fact, I am so happy to see so many of crowd at the last session of the last talk, of the last day of the conference, of the successful. And thank you very much for staying back with us. And here I am trying to cover a little bit about more of secondary IOLs, what to choose. Unfortunately, the small micro HDMI is not working with them. So I'll just tell it with a few videos first. I'm sure that most of you know how to do an anterior vitrectomy. I'll not go more into the details of it. If there is a PCR and if there is a meiosis, then always try to use the pupillary hooks or whichever best suits your hand to just see the extent of the PCR so that you can go ahead and avoid multiple surgeries. And the most important is to use the dispersive viscoelastic. And the next one is first try to do a dry vitrectomy, because as a vitreoretinal surgeon, and I'm seeing so much of crowd, another thing for me to be happy is we don't get so much of crowd in vitreoretinal surgeries whenever we show. So it's always been happy to be a part of the phaco part so that we get some crowd, so that we have people to listen to this. So in a dry, always it's better to do a dry vitrectomy, is because whenever you start with an irrigation, when you're off the irrigation, there is a chance of extension of the PCR. So always do a dry vitrectomy, but most important thing is avoiding AC collapse. Sometimes we keep on doing dry vitrectomy where everything goes off and the AC collapse suddenly again, AC collapse ho gaya, fir visco. So to avoid that, you have to balance between the dry vitrectomy and the bimanual vitrectomy. Then once you do a dry vitrectomy, then go with the bimanual vitrectomy. And while placing the bimanual vitrectomy, you can see here the laser pointer. You can see here the irrigation always try to get it over the iris or at the peripheral area, not at the area where you have a PCR. sometimes when you just on the irrigation, that irrigation fluid itself might extend the PCR. So always try to keep the irrigation port away from the area. Then try to preserve the rhexis. Then comes the cortex aspiration. I know most of these modern machines have both, you can toggle between the vacuum and the cutting. When the earlier machines where only you had to have a vacuum where cutting again used to have it, but now you have a toggle at the foot switch where you can just press like how the modern days vitrectomy machines are, like 23-25 gauge. Similar way, even the anterior vitrectomy also comes with a toggle. Just try to bring it to the center and then cut it. Just try to aspirate, put the vacuum, bring it to the center, put the switch toggle and then cut it. And avoid pull on the capsule and the zonules. And then most importantly is try to confirm before you finish your anterior vitrectomy. I always suggest to use IVTA because it helps the vitreoretinal aspect also. Why? Because there is the media of inflammation. Any vitreous, whenever any cortex goes into the vitreous, that's the cause of the inflammation. And most of us has in mind when to refer it to a vitreoretinal surgeon. Need not panic. Most of the meta-analytic studies have shown if there is less than 1/3 of the cortical piece, then you can usually observe. If there is a nuclear piece, you have to refer it. Why? Because the nuclear pieces induces inflammation more than the cortical pieces. So if this is only a cortical piece, you can observe it. Of course, you have to make sure that there is no vitritis, there is no AC reaction, there is no secondary increase in pressure. You can always observe them. But if there is a nuclear piece, it's always better to send it off because the eye might be silent at that time, but you will have chronic edema for years together, for which we keep on pumping Ozurdex. I have seen many cases in my 7 years of practice where I have given lots of Ozurdex for these patients where the nucleus or the cortex might have absorbed, but still that mediator, inflammatory mediator still keeps on going continue where again after doing a vitrectomy they settle down. So it's always better if there is a nuclear piece, please refer. If there is a cortical piece less than 1/3, you can always observe it. Then if you're not sure to have a good support of IOL, always better to consider for scleral fixated, iris claw. I usually hate AC lenses, but as a part of it, it has to be mentioned. So should an IOL be implanted? As a vitreoretinal aspect, I would like to give a few points. Always avoid because there is a chance of dislocation. If there is a large PCR, it's always better to avoid it. I'll tell why later. The second one is choice of IOL, of course, is 3-piece. Avoid because it reduces visibility for a VR surgeon. Many of us I have seen that in hurriedly they do it, and because, please don't take me wrongly, my anterior segment colleagues, but sometimes we charge the patient so heavily that we have to place a lens and send them back. That's actually a very bad idea. Most of them do that. So what I suggest is if you have a lens drop, if it's a nucleus drop, please do not panic. It's always better to have a good vitreoretinal surgeon as your friend also. Okay, so whenever I have seen many of the doctors, what they do is whenever there is a nucleus drop, they put the lens and then send them. See what happens while we put the trocars and when try to do the maneuverability, sometimes the dislocation of IOL is also possible. So in that cases, when we want to enlarge it, say for example, it's a grade 5 nucleus. Okay, we prefer to do an impaling technique rather than cutting it with a phaco-fragmentome or with the 23 gauge fragmentome because it has a lot of power to cut that hard cataract. So what we do is impaling technique, we try to put a needle and bring it through the, extend the corneal incision or make a scleral tunnel incision and try to bring it out. So always I suggest my anterior segment colleagues to avoid in such cases. And unless the capsular support is good or small dropping is there, definitely I suggest please go ahead with the placement of the lens in the back. And with the time, why I said to avoid is, with the time, the capsule becomes more and more stiffer and well defined. Then the lens can be placed in the sulcus much better. So that's the reason why the vitreoretinal surgeon suggests not to do immediately at the time of having a large PCR. Nowadays we have shifted to doing 3D surgeries. Yeah, this is how we are doing it. So how does it benefit us during using the Ingenuity systems and all those things? It gives a higher magnification, good field of view, and you have a better depth control, and the field of view is also much better. So I will just go through a few of the cases how we manage in case of nucleus drop. Here you can see I'm just put an IVTA, and always I prefer to use do a Pvd induction. And once I do a Pvd induction, you can just see the hard cataract lying there in the vitreous cavity. So just like how you do a phaco in the anterior segment, we try to do a phaco in the posterior segment. Just try to put some vacuum, bring it to the center of the vitreous, and then just press your foot well. Just completing the vitrectomy. Completing the vitrectomy is very important. Some surgeons prefer to use PFCL because any nuclear fragment or any fragment should not hit the macula while emulsifying it. Just bring it to the center and start emulsifying. Bring it to the center, start emulsifying. So this is the way we can just try to make it into small pieces and then eat it up. Not go into the more detail because not be of, yeah. So now, what are the different choice of lenses or secondary IOLs available? Now you can easily fix the iris claw lenses. So we did a study with 100 iris claw lenses versus 100 scleral fixated, that is sutured lenses. And we found that sutured SF IOLs are much better than iris claw, is because secondarily, if the patient develops any retinal detachment or if he develops any retinal complication, the gas or the oil can definitely go into the anterior segment, complicating the cornea much more. So always avoid to use an iris claw as much as possible. If you don't have any of the other options, then you can definitely go ahead with iris claw because it is again less traumatic as compared to the SF IOL. Now coming to different kinds of SF IOL which you want, I'll not show more into the sutured SF IOL because of the time, but I want to focus more on the sutureless SF IOLs. Here you can see, just make a small 2 flaps like how we do a sutured SF IOL, and just use a 23 gauge or a 25 gauge trocar. So once you make an entry there in the pars plana area, and then just take one haptic and use the ILM forceps. And if you have a vitreoretinal surgeon with you, you can do it yourself. You don't need a vitreoretinal surgeon for this, but please don't take his good ILM forceps. Use the condemned forceps because this ILM is going to go waste. The forceps is going to go waste. So take that, externalize it, and once you externalize it, you can make a small, I usually prefer to use, earlier I used to use this side port blade, but now I use a 26 gauge needle. That's much smaller and less area so that the haptic sits in the tunnel very neatly and nicely. So here I am again taking the other end and just trying to place it and apply the glue or the suture, whichever you want, and that's it. Now coming to the another technique is the Yamane's technique. I just, when Dr. Satanshu Mathur said you speak a little bit about the secondary IOLs, I thought I will just record it. I recorded just a day before I came to AIOS. So this is another technique is called as the Yamane's technique. In fact, I earlier had a lot of skepticism about this technique, but after one surgery, I think everybody can, if I can do the surgery, then you people can do it much better. So here what I'm doing is, earlier I used to use a 30 gauge needle, and later after entering inside, I realized that the edge of the needle will not allow the haptic to go inside. Then I shifted to 26 gauge needles. So the advantage of these 26 gauge needle is it's slightly wider so that the haptic can go inside to dock it. Here you can see I'm using ILM forceps to dock it inside the needle edge. So once you dock it, some of them prefer to pull it at the same point, or I prefer to keep it at that point and then go ahead with another haptic. In fact, the challenge is more with this haptic because it has to be oriented in that way, and whenever you are making a 26 gauge, make it straight perpendicular to the parallel to the limbus and then go inside into the vitreous cavity. So once you dock the second haptic, and then simultaneously you can just pull both the haptics together. So once you get one haptic out, just hold it and then go with the second rotation. Bring out the second haptic. So once you bring out the second haptic, then you can apply heat cartridge, whichever kind of heat cartridge you had. In fact, just yesterday I purchased a good heat cartridge, but you can do it if you have a ballpoint cartridge also, which you used to have earlier days, which you used to do. You can see here, use the heat it up well, and then just use a ballpoint cartridge. You can see it becomes flat. The bulbous, you get it with the heat. With the ballpoint, you get a flat surface. That's okay. And the other end also, I'm just trying to heat it up. And once you heat it, you really have to make a bulbous or the flat kind of insert so that it stays there well. and then just push it. In fact, I earlier thought that you do not have a control of how much to heat it. I was wrong. In fact, the forceps which you hold, that itself acts like a guide. And once you hold the forceps, the heat will not traverse below the forceps. So whenever I used a ballpoint cautery, it used to come to the edge where I used to hold the forceps. So it acts like a good guide. In fact, centration is very perfect in this. I was again skeptical that sutured are always better because they are well centered. In fact, this also having a good centration is because you can just pull it again and then heat it and then push it back. If you think that it is still decentered, then take one of the haptic. Still, you have a a space to make it well centered. So that's about the Yamane's technique, and we have put this as statutory warning in our department of vitro-retina that do not implant an IOL if a PC rent is more than 3 mm. But I know you're all classic phaco surgeons, so it's all left in your hands, whichever is possible. So I'll not go into the details of it, and with this, I thank you very much for your patient listening on the last day of the last talk. Thank you very much. Thank you, Satanshu sir, and all the respected delegates. Yeah. Yeah, good question. Even I had the same thing where it pulls out, it doesn't come out. It holds very well actually. Very nicely. Very nicely. In fact, if you saw, the Amana described to bring it out both together at the same time. So that in the same rotation. But here, if you saw, I brought one end out and I brought the second one out also. But still it did not. So have a good part of the haptic into that edge of the needle. Even if certain part slips, but still some part will still remain. No. As of now,
You can use a 30 gauge thin wall.
thin wall.
Yeah, thin wall is available.
Okay. But does this, because I tried with two IOLs, one is the sensor haptic.
Not the normal 30 gauge. It
Ah.
has to be 30 gauge thin wall.
Thin wall.
From Velasco. Velasco is the company. So that goes in, and then the most important thing is that the proximal failing haptic is a very important.
Important, yeah.
So there are quite a few modifications. So what I do is when I take the first one inside, I use the sensor so that when it comes out, I just pull it out. Then I just pull it out the one. The second one, I bring the needle out with a trailing haptic outside. So when it is outside, you can see it becomes easy.
Yeah, easy to do that. Yeah.
So then
Several modifications, yeah. I agree with that. But I always suggest to use as thin bore needles as possible. It's because if you have a 26 gauge entry, there are all the chances that if you don't have a bulbous end, it might slip out. Yeah. Always try to have a thin needle possible. I think it's a good suggestion. What's that called, sir, again?
Velasco is the company.
Dilasco. I think you all can try that and try to get a thin needles. That always works better.
You get 100 for $130.
Thank you all of you.